Good morning, good afternoon, and good evening, everybody. I see the participants are entering the webinar now. I think we'll get started as people continue to enroll into the webinar. It is my pleasure to kick off this third webinar in the Path to Access to Care and Treatment Comprehensive Care Series. This series has been designed to support healthcare providers in setting up and strengthening comprehensive care in their centers. The first webinar, which took place in September, covered the multidisciplinary team, their roles, and key components of comprehensive care. The second webinar covered the delivery of comprehensive care, how to set up diagnostic services, and conduct patient outreach and identification. And today's session will focus on how to effectively collect and use data to inform your clinical practice and improve health outcomes for people with bleeding disorders. My name is Donna Coffin. I am the Director of Research and Education at the WFH. Thank you. Thank you very much for moving the slides. The PACT program is supported by funding from our leadership partners, CSL Behring, Pfizer, Roche, and Sanofi, as well as our collaborating partners, Biotest, Grifols, and Sobi. We're grateful for their support of this flagship global program of the WFH. Before we get started, I'm going to go through a few housekeeping slides. You will notice on the bottom of your screen, there's an interpretation button. We are offering the webinar in Spanish, French, Arabic, and Russian. You can just click on the interpretation and choose your language. If you are joining by mobile phone, you have a little bit of a different setup. So on the left-hand side, the screen of the phone is for an Android phone. You'll see 3 dots at the bottom of your phone. You can just click on that and choose your language. The middle is for an Apple phone. You can choose select your language on the interpretation button. You then have to go to the top of your screen and click done to be able to actually listen in your selected language. For questions, you'll see the Q&A button at the bottom of your screen. Please send any and all questions through this button. We'll be collecting the questions throughout the sessions, and we have 15 minutes or 20 minutes devoted to at the end of the webinar to go through all of the questions. So please send us your questions. During this webinar, we will be having a few poll questions. So I think we have 3 in total. A poll question will appear on your screen. You select your response and it will automatically go to WFH in the background. We'll compile the results and display the responses. It's all confidential and anonymous. Thank you for that. So it is my pleasure to introduce today's speakers. Our first speaker is Dr. Alfonso Iorio. He is the professor and chair of the Department of Health Research Methods, Evidence and Impact at McMaster University in Canada. He is the PI of the web application for population pharmacokinetic in hemophilia. That's the WAPS project. He is co-investigator of the patient-reported outcomes burden and experiences. That's the PROBE project. And he is chair of the Canadian Bleeding Disorders Registry. He is also past president of the WFH Data and Demographics Committee, and currently he is co-chair of the World Bleeding Disorders Registry. Welcome and thank you, Dr. Iorio. We also have Dr. Catherine Lambert, who is an adult hematologist in the Division of Hematology in Brussels, Belgium. She is actively involved in the WFH twinning program, and she is also, along with Dr. Iorio, co-chair of the WWDR. We have Dr. Mieti Ondogomo, who is a hematologist at the University Hospital in the Ivory Coast, where he's been responsible for hemostasis disorders, including hemophilia, since 2010. In 2018, his center, along with Dr. Lambert, was awarded the HTC Twinning of the Year Award. We have Dr. Marius Coetzee, who is a semi-retired academic hematologist and has been involved in the bleeding disorders in Central South Africa for most of his professional career. He received the WFH IHTC Fellowship Award in 2003, and he is a champion of the WWDR, and we'll be talking today about the My WWDR Patient app. He's been involved in the WWDR and enrolling patients since 2019. And last but not least, we have Dr. Tahira Zafar, who is a professor of hematology and director of the HTC in Rawalpindi, Pakistan. She's also a founding member of the Hemophilia Patients Welfare Society and has worked in various prestigious institutions in both Pakistan and the UK. Dr. Zafar is also a WWDR champion and will be presenting on her experiences using data from the WWDR. With that, it is my pleasure to introduce my co-chair, Dr. Alfonso Iorio, to go over today's agenda and then present an overview of how and why we collect data.
Thank you very much, Donna, and good day, everyone, wherever you are. It's always a pleasure to be on meetings or calls with people from this part of the world. So nice to see all the greetings that are flowing in the chat. The agenda is on screen. We have covered welcome and introduction. We will now move to a few considerations about how and why we collect data. Go back for a second to the previous slide. Then after the introduction, we will hear about how to use WWDR, the World Bleeding Disorder Registry that WFH is supporting to measure health outcomes, how to collect patient-reported outcomes, improving care delivery using data. We will have plenty of time for Q&A. You are welcome to put your Q&A, your question in the question function during the presentation. We will keep them until the end and do our best to answer them. And then we will wish you a good rest of the day. That said, let's move directly into how and why we collect data. I will be providing this initial consideration. So why we are so interested in data? Because data is powerful. Data is what make us progress in research. It's what enable us to provide better care. Is what we need for advocacy. No matter what the goal is, data is important. It's getting more and more important with better data collection capacity, but that's really something we cannot live without. I like to think of data as the fingerprint of health processes. The data is what is left after things happen and is what is needed to improve how they will happen in the future for new patients. Next slide. So the importance of data is in the collection, is in the information they contain. I want you to think for a second, what is the meaning of the word? Data is a Latin word, and it actually means given, is the past participle of the verb that means give. So data are actually left by the owner, are left by the person, are left by the patient behind them when they move. So that's the original meaning. And you know how current this is, all the discussion around use of data by big tech company, who owns them, what they can use for. You don't collect data. You just use Google Maps, you use Google to search, and data are left behind you. And those are very, very full of very important information. For research, we have built on an additional layer, which is collecting data, making sure that those fingerprints are collected properly, are interpreted properly. This is what data is. Next. Now, what are registries? Registries, again, are logs of data. And ideally, we say registries collect real-world data, as opposed to clinical trials. In clinical trials, we instruct people what to do. We decide exactly which treatment they receive. We do a lot of tests and observation to see what the effect is. It's a sort of an artificial environment where we generate data that are research grade. Registries collect real-world data, collect the data as things happen. Why? Because of the power of data. I hope I made that clear. And how, as much as possible, capturing those data without affecting the course of life. Our patient and our doctors, all of us, we want to know what is the result of using best care in a real-world setting without impacting too much the life of our patient, the way the treatment is intended to be used. That's what registries are here for. Next. So running a good registry, doing a good data collection is a balancing act between observing without changing anything of the natural course of event and imposing some control that makes the data more valuable because they will be standardized, they will be better fit to answer your question. And it requires work. Even if it's observing what happened, you need time and people, you need your own time and your patient time for the data to flow into the registry. And there are two main paradigms. One is you do it for a cause. You do it because you want to serve the community. You do it because you believe it's good to be done and it will help future patients and future doctors, or can be done as a business. Again, think of the big tech company, or think of data collection in hospital or for research. It's a business, there is money that is generated, and in those cases, I believe, and many of us believe, there should be a fair share of the benefits to everyone, including the patient who are generating the data. These are the two main paradigms for registry business models. Next. So I will not discuss today data ownership, data protection and safety, privacy, ethical aspect. We might go back during the discussion to some of these aspects. These are very important, are on this slide because it's not that I ignore them, it's not that they don't matter, I don't have time to cover them. I want to cover 4 aspects of data collection. Next. The 4 aspects are the data needs to be representative, needs to be complete, meaningful, and accurate. That's what makes data good. So let's look at these characteristics one by one. So next, data representativeness. The data are more valuable when they properly represent the population we are interested in. If we want to learn about hemophilia treatment in one center or one country or worldwide, ideally, we either want all cases. Otherwise, we have a distorted version. All cases, a random sample of cases, or if we can't get to all, or if we can't get to a random sample, whatever convenient sample, whatever group of patients we can reach, but describing very well what we did and what we didn't. So for example, all patients in a country would be a perfect data collection. It for sure speaks to that country population. Even 1 in 10 patients known to a center would work. I collect data, I don't have resources to collect in everyone, I collect data in 1 every 10. There is a good chance I get a photograph that is representative of the entire population. Or I may say I can only do this in March, but then I have to be honest and transparent and say I collected every patient who came in March. I collected data from every patient who was in the center and was willing to give their contribution, provided I transparently say there is still value. This is representativeness. The next slide speaks about completeness. Most of the power of data is in connection between different information. If you think of, Netflix, the power of data is what I've watched, for how long, which show I did stop watching, and which one I came back consistently, and what my age is, my language, and my occupation, and so on. The power of data is in the connection between different points. So it's important to collect the entire set of data for each of the patient, and possibly to have complete data. If you think of, you want to explore adherence to treatment or efficacy of treatment, you need the bleed and the treatment logs, and they are valuable if they are complete. How you get complete data? Really, the most effective way is engagement. You need to make sure that those collecting the data, they understand the importance of collecting them properly in a complete way, and make the collection simple. If the collection happens when you use Google Maps, you don't even realize that every time you use Google Maps, you are leaving data for Google to analyze. Let's imagine ways where the data collection happens while we do what we will be doing anyways for our treatment. A way of checking completeness of data is a triangulation, is checking different sources for the same information. Data completeness really cannot be improved beyond a given point, and it becomes a double-edged sword. You have the data you have. They may help you or they may bite you back. If you can't do a good data collection, maybe don't do it at all, because it will not help you, may actually show that treatment is not so effective, that is not so needed, and so on. This is very, very important, both politically and scientifically. Next, meaningfulness. It takes time. It is costly for individuals to collect data. So the data point, the information we collect should be meaningful. I need to understand why I'm collecting what I'm collecting, why I'm doing this extra effort. And this is why setting up successful registries is a long journey. You need to trust the organization that set up the registry. You need to trust that they know what they are doing. And usually trust comes from seeing the organization taking time to explain you, and you taking time to explain your patient why it's important to do that data collection activity. It has to have a sharp design. If you ask yourself, why am I adding this information, you will stop doing it. So ask, let that be clarified. If we really don't see the value, let's drop that piece of information. And everyone should see some gain immediately, no matter if you are a patient, a doctor, a registry manager. The sooner you start showing what the data are used for and how good and rich they are, the better you will create a positive spin on the data collection. Next and last, data accuracy. Data are powerful and they have their own power. So we really need to be respectful and try to understand what they say. Data may not say what we want them to say, but they will tell us the truth. If we do proper triangulation, if reporting is transparent and complete, if you ask the question first and then we take whatever question comes out of the data, we will improve. If we go to data and we, insist changing the way we use them until we get the answer we want, we are really wasting time. That's called data fishing or data dredging. Data can give us the answer we want or a different answer. That's the answer that is real, is the answer we have to start from. We decide to collect data with a tool, and then it doesn't show an effect of treatment is not a problem of the tool. If we have done our due diligence and we showed the tool well, maybe treatment does not affect that aspect. We cannot change continuously what we want to show and what we hope to show. This is the last part of data collection, is when you look into them, it should be automatic, should be really respectfully looking at what our hypothesis made us think, what we have collected, making sure they were precise. Either we failed in the data collection or we failed in generating the hypothesis. We cannot blame on data. So to me, data accuracy is partly having good data and partly is being honest the way we look at them. And this was my last slide, I believe. So I'll thank you for your attention. I'm sure I have not made all clear. Feel free to ask questions, to make comments, or even to disagree. We are all here to learn together. Said that, we will move to our first poll question. So there are a few of these questions during the webinar. There is no right or wrong question. This is a way of collecting data on ourselves, on those who are on this webinar, and try to see where we are from and try to learn from what others do. We will not show individual responses, so your response will stay confidential. We will show the overall result. You will see a poll appear, and you have a chance of choosing your best guess, or some questions require more than one. I will read the question slowly while we proceed with the polling. So the first question is, which data collection programs are you currently participating in? And you may select more than one for this one. A, Hemophilia Treatment Center Registry. B, National Registry. C, NMO Registry. D, WWDR. E, other type of registry. And F, not participating in any data collection program. Select all those apply to your case, please. Okay, we have now the result on screen, and you see that I hope you see the result like I do, but again, quick comment, 60% of the participants collect data in an hemophilia treatment center, and shy of 50 in a national registry. This is actually very good. 40 in the patient organization, and again, close to 50 for WWDR. There's a very small minority doing other type of registry. We may get there during the discussion. And there's a 10%, not yet, I'd like to say or to think, not yet collecting data. Hopefully we will convince them that there's value in collecting data. Thank you very much for voting. Let's move on. It is now my great pleasure to introduce Dr. Catherine Lambert and Dr. Mitei Ndogomo to discuss using WWDR data to measure health outcome. Please.
So, dear colleagues, welcome to this lecture on using WWDR data to measure health outcomes. My name is Dr. Catherine Lambert. I'm hematologist at the Hemophilia Treatment Center of Brussels in Belgium. And today I will share the floor with my colleague, Dr. Ndogomo Meite, hematologist at the Hemophilia Treatment Center in Abidjan, Ivory Coast. Meite will give the first part of this talk, and I will come back in a few minutes.
Merci, Catherine.
Thank you, Catherine. Our presentation today will deal with the following points. I will start by talking about hemophilia care in Ivory Coast. and present the twinning between Abidjan and Brussels hemophilia treatment centers. Afterwards, Professor Catherine Lambert is going to describe how the WWDR registry was implemented in Ivory Coast. She will end with a discussion on the practical impact and the potential of using the WWDR to improve hemophilia care in the Ivory Coast. Ivory Coast is a West African country with an estimated population of about 28 million inhabitants as of 2021. We have a hemophilia treatment center located in the capital, Abidjan, with an annex in Bouaké, in the center of the country. The patient organization was created in 2008. We observed major improvements in hemophilia care and management over the last years. With the support of the World Federation of Hemophilia, we managed to achieve an HTC twinning with the Brussels Hemophilia Treatment Center from 2014 to 2018. For this twinning, care was organized in our treatment center with the following elements: standardized multidisciplinary consultations, structured medical records, logbooks for patients where records are kept of their bleeds, whether treated or not, and the different treatments that patients receive, regular biological workup with screening for inhibitors, regular data collection, familial screening with systematic screening of newborn boys very soon after birth, information and education of carriers, particularly regarding hemophilia transmission, and information and education of patients and families. We have performed a vast data collection campaign in 2017 in the context of the World Federation of Hemophilia Twinning Program. Such data have been published in an article published in the journal Hemophilia. This was the foundation for the first hemophilia registry in Ivory Coast. In the same journal, we have published an article on inhibitor epidemiology and genetic-related risk factors in people with hemophilia from Ivory Coast. We have only one treatment center in the country right now, but in collaboration with the patient organization, we are developing networks focused on hemophilia care across the territory, in Bouaké, in the center of the country, and in Yamoussoukro. We are also involved in the education of community centers about hemophilia, the dissemination of knowledge about hemophilia care, as well as the sustainability of the treatment center located in Abidjan. Here is a summary of the evolution of hemophilia care in Ivory Coast during recent years. Until 2014, clotting factor concentrates came exclusively from humanitarian aid. There was limited access to clotting factor concentrates. There were no patients under prophylaxis. There was no elective prevention of bleeds by clotting factor concentrates administration or hemostatic treatment. And since 2014, we have gained increased access to clotting factor concentrates under the World Federation of Hemophilia Donation Program. Children have benefited from low-dose prophylaxis in 2018 with clotting factor concentrates. We have been able to perform circumcisions and synovirothesis for patients who needed these procedures with preventative treatment with clotting factor concentrates. All these efforts have permitted the recognition and inclusion of hemophilia in the national program by the health authorities in 2021. Since then, the Ivory Coast government has entered into an agreement with an industry partner with the aim of promoting emicizumab donations. Thanks to these donations, around 30 children received prophylaxis with emicizumab as of 2021. After this update, I give the floor to Professor Catherine Lambert for her to continue this presentation.
Thank you, Maite. So in the next slides, I will try to highlight how hemophilia care in Ivory Coast was improved by implementing the WWDR. It was implemented in 2019, and actually there is more than 80% of the Ivorian hemophilia population that is enrolled in the registry. The implementation took place in the frame of the twinning between Brussels and Abidjan. Brussels already joined the WWDR in 2017, and thus it was an opportunity to share with Abidjan our experience to get ethics committee approval to provide IT support and training to record data. As Dr. Maite already explained, the use of logbooks and medical files structured according to data requested in WWDR were used already since a few years. And this really helped to transfer smoothly the data in the WWDR. The enrollment took place during a twinning visit in Abidjan. It was really well received with a record participation. As you all know, there are some specific data that you can find in WWDR with respect of demographics, diagnosis, and clinical of patients with hemophilia. In bold, you have some mandatory items, and other items are optional. In the next slides, I would like to highlight the outcomes and the potential value of participation to the WWDR, namely in Ivory Coast. First, it allowed to measure the outcomes of prophylaxis and selective preventive measures. And we could really measure this by an increased number of identified people with hemophilia, a reduction in the annual bleeding rate, a lowering in the age of diagnosis, an increased access to treatment and prophylaxis, more data on inhibitor, and less target joints, at least in children. Participating to WWDR also provided objective data, allowing comparison with other countries, developed and developing countries. And here I show you a presentation from the WFH last year, where we had a direct comparison between the Ivorian and Belgian hemophilia population. Another opportunity of WWDR is to enable the identification of local needs, for example, the amount of clotting factor concentrates, the need for physiotherapy, screening, educational program, and outreach. By using the data from WWDR, we could also develop national action plans and initiate negotiation with stakeholders, not only the health authorities, but also the direction of the hospital where the hemophilia treatment center is located, and industry, for example, for the emicizumab program. These data are also useful to advocate for a sustainable access to hemophilia treatment and prophylaxis by knowing, for example, the number of patients, the annual bleeding rate, the number of hospitalization days, and the education and employment status. On a more global aspect, participating to WWDR enables the participation in clinical trials, international trials. It also helps to initiate international collaboration and provides to the center the feeling to become an active partner on the community level. It also allows an active participation on global knowledge on hemophilia. And in some cases, it also helps to access some funding. So I hope that with this presentation, I could highlight the major benefits and opportunities of participating and using the WWDR data. And this is even more beneficial in developing countries and in the context of setting up and improving hemophilia care. And finally, it also shows the input of a twinning to share experience and facilitate the WWDR implementation. So on behalf of Dr. Meite and myself, I would like to thank you for your attention.
Thank you very much, Catherine. Thank you, Meite. It was an excellent presentation. I forgot to tell everyone earlier that you can type your question in your own language and we will have them translated. Please overcome your shyness, type your question. I'm sure you have many, either in English or in whatever language you like. Said that, let's move to the second contribution we are asking you to provide, the second poll question. You know already the rule of the game, so I'm reading the question for you while the polling will appear. What challenges do you face in participating in data collection programs? Again, you can select more than one answer here. These are the answers. A, staff. B, resources. C, time. D, regulatory approval. And E, do not face any challenges. Take your time, select all those challenges that apply to your experience. 9 in 10 of you declare doing data collection, so I'm sure we will learn a lot from you answering these questions. You have seen the power of data in the presentation of Professor Lambert and Dr. Ndogomo. So we want to help overcome challenges in repeating similar experience elsewhere. Here are the results. Again, 3 in 4 face problems with human and financial resources. And we know that collecting data takes time, human time, and cost money, both to pay for that time and sometimes to pay for infrastructure. It's nice to see that these are barriers everywhere. One of the additional barrier is that when we work in isolation, we think, oh, this is too complicated. I cannot do it. It takes too much time. I don't have enough resources. I cannot do it. It's the same everywhere. And where that is overcome, maybe is because money is available or resources are available. Maybe that really applies to a handful of country and a handful of setting. Even in my own setting in Canada, data collection happen mostly for engagement and for goodwill of those collecting data. These are common barriers, and we believe that sharing that those are so common, 3 in 4, should make us feel we can overcome them. Okay, let's move on. And is now my pleasure to call up for presenting Professor Marius Coetzee, and he will tell us about patient-reported outcome. Please, Marius.
Hello, ladies and gentlemen. I'm Marius Coetzee of the Department of Hematology and Cell Biology at the University of the Free State in Bloemfontein, in the middle of South Africa. And I'm giving this talk in conjunction with Dr. Lariska Hoopt about collecting patient-reported outcomes using the MyWBDR mobile application. The topic is divided into two halves. Firstly, we have the patient-reported outcomes, and we're discussing them, what they are, and why PROs are important. In the second half of the talk, we're looking at the MyWBDR as a PRO tool, what it is, what information is recorded in the app, what features it has to offer, and what benefits it's got. The problems we were experiencing before it became available to us in July of this year was that we had a lack of patient-reported outcomes data. We and the patients didn't have a sense of ownership of the data. We had tried paper diaries for years, but they were not completed, left at home, or just lost. So it was very difficult to collect and collate data, and this made research difficult. On top of this, the pharmacy was worried about us actually showing what we were doing with all the medication they were issuing. So let's look at the WFH treatment guidelines. Recommendation 11.2.1 recommends that the frequency of all bleeds is documented in real time by patients or caregivers, and that this is reviewed together at least annually. And then recommendation 11.7.1 recommends that we document the musculoskeletal and overall health of each patient at least annually, and that we can do on the WWDR website. Secondly, it recommends that we collect functional activity levels, like the Hemophilia activities list or the functional independence score in hemophilia. Both these are available on the WBDR. And lastly, it says that health-reported quality of life is an important aspect of outcome measurement. So let's discuss what patient-reported outcomes are. Basically, they answer the question, is our treatment making any difference in the patient's lives? PROs are health data provided by patients, and PROs include the health status, quality of life, like, for instance, symptoms, functionality, physical, mental, and social health. PRO data can also be collected before, during, and after interventions. So, what are patient-reported outcomes? They provide information on the patient experience. They can assess the effectiveness of healthcare interventions from the person with hemophilia's perspective. They are actually the patient's voice. PROs provide data for people with hemophilia, healthcare professionals, researchers, insurers, and policymakers. They have been used in other chronic medical conditions. And on top of that, the FDA and other regulators actually require PRO information before licensing new drugs. So the solution is actually a mobile application, the MyWBDR. There's the icon on the right. And this collects the following PRO, the bleeds, treatments, and quality of life. It helps people with hemophilia to take control of their hemophilia care. What is the MyWBDR? It's a secure mobile application from the WFH World Bleeding Disorders Registry. It's a tool that collects PRO. It allows people with hemophilia to track bleeds, treatment, and changes in health status. It empowers people with hemophilia to participate in the WBDR. And it enables healthcare professionals, hemophilia treatment centers, people with hemophilia, all to contribute to research in hemophilia. So, what information is recorded on the MyWBDR? There are 3 modules. On the left, we see the bleed module, all the information about the bleed. In the middle, the treatment module, which collects everything about the treatment. And then on the right, the quality of life module, which has 2 options, the MyProbe and the EQ5D5L. So why is it perfect for people with hemophilia? Well, starting on the left, it can record bleeds and treatment in less than 1 minute. It's secure and accurate, and the data is transmitted to the WBDR. And lastly, it can also provide simple data visualization of bleeds and levels of pain over the last 6 months. So let's climb into it. After you've downloaded it on the phone and registered, you select the language, and then on the right, you can see places for recording bleeds and treatment. So what are the main features? Starting on the left, there's the facility to record bleeds and exactly where they are anatomically. If we move to the second panel, it can record the patient's pain level, and then on the right is the record for treatment. So the date, time, where it was done, and then all the details about the drug. There are some very fancy visual features of the MyWBDR. You can see on the left that this patient has had more bleeds in the beginning of the year. And in the middle is a pie chart of all the bleeds in the last 6 months. And you can see in the light blue and blue that there have been 10 serious bleeds. And on the right, it shows that the patient had mild pain for most of the time. Carrying on, we also have a calendar view on the left. And there you can see days on which there were bleeds in pink, and then the days on which treatment was given in blue. The details are further down in the screen. If we move to the middle, we see the patient-reported outcomes screen. And in the blue, there is the probe survey, which was designed by patients in the WFH4 patients. And below that is the EQ5D5L survey, which is fairly quick. It's standardized internationally, and lots of countries have data for healthy people. So what are the benefits of the MyWBDR? Firstly, for people with hemophilia, it eliminates the need for paper diaries. It facilitates quick bleed and treatment data entry. It records and tracks changes in health status through the EQ5D5L and the probe questionnaires. And on top of that, it functions offline. so that data can be recorded without internet connection and then uploaded later on. And for clinicians, the advantages are that it transmits data to the WBDR and provides accurate and complete patient-reported outcomes. Here we have the WFH's data collection tools in the form of the WBDR website for clinicians, and then on the right, the My WBDR, the tool for people with hemophilia. And the beauty of it is that all this is integrated to collect real-world data on patient clinical care and quality of life. Here I have a screenshot of the web view of a patient who has been recording his bleeds. I've just blacked out the personal details. So on the top, we can see that he's had bleeds in his left leg and specifically his foot, and that his pain was mild, and that he also treated it. If we look at the details below, we can see in the two top lines that he actually gave himself on-demand treatment, and he gave himself 4,000 international units. And below that, we can see that he actually recorded his prophylactic treatment. The MyWBDR, by incorporating patient-reported outcomes into clinical practice, it actually creates a 360-degree clinical evaluation for better care and treatment of people with hemophilia. Thank you for your attention.
Thank you, Professor Coetzee, for your presentation. We now move directly on to Dr. Tahira Zafar for discussing improving hemophilia care using data. Tahira, please.
Hi, everyone. I'm Tahira Zafar, and I'm a hemophilia treater working in Rawalpindi, Pakistan. It's a pleasure to be talking about something which is very important in hemophilia care, and that is data collection. Registries have been going on for a very long time in North America and Europe, and WFH has also been collecting and publishing data since 1998. But this is not the case in Asia and Africa, where data is still lacking. And it was realized as early as 1997 in a joint meeting of WHO and WFH that in developing countries, development of a national registry of people with hemophilia is a key priority. In registries, the data is actually collected in a very systemized and organized manner, and it helps us not only to know what our patients' needs and requirements and numbers are, but also help us to follow their clinical course and then make clinical decisions. A number of practices which are now part and parcel of hemophilia care have been developed due to data collected in the registries, for example, prophylaxis. In Pakistan, data is collected on different levels, at the local level, at the national level, and at the global level. We have, at the local level, we have 4 major HTCs, which are affiliated with the hemophilia societies, and they collect their data. This data is also goes on to the National Patient Registry, which is managed by the NMO, the Hemophilia Foundation of Pakistan. At the global level, we are part of the World Bleeding Disorder Registry. If we look at the local data from my center in Rawalpindi, we can see clearly on this graph that over the years, not only the total number of patients increase, but there is also increase in new patients. That means that our awareness and our outreach is going in the right direction. But how right it is going can be seen in the next slide, where according to our catchment area population, we should be having around 3,000 hemophilia patients. But if you focus on the number of hemophilia patients here, we see that only 700 patients are known or diagnosed or registered with the center. This means that we really need to have targeted awareness and outreach so that we acquire more of these patients and bring them to our folds. When extended half-life factors were donated to Pakistan through the humanitarian aid program of World Federation of Hemophilia, we actually started a study to see their efficacy and also compare them with standard half-life products. If you look at this slide, the bars in blue are the standard half-life products, while the ones in red are the extended half-life product. If you see, it is clear that not only the number of bleeds have reduced in extended half-life product, but also the number of injections. And with the decrease in the number of injections, the dose per bleed is also reduced. In addition to that, there has been minimal side effects, and all the patients who were tested didn't show the presence of inhibitors. In conclusion, we can say that extended half-life products has prolonged activity and results in reduction in the number of bleeds, the number of injections per bleed, and the dose required per bleed as well. It has minimal side effects, and it has not shown any inhibitor development in patients who actually received it. So this actually, collecting this data has enabled us to know that extended half-life products are very useful. Coming on to low-dose prophylaxis, this was initiated in 2018. And when we started it, we actually started collecting data as well and compared it with on-demand treatment. And the comparative data actually shows that there's reduction not only in spontaneous bleeds, there's improved joint health, and there's also reduced factor utilization. When we started the low-dose prophylaxis, we weren't sure how well it will be taken by our patients and their parents. But over the years, we have actually seen that the compliance has been 86%, and that has been due to the care and commitment by our staff. Some of the patients actually, because of the regular visits, have become so familiar and confident that they leave their parents in the waiting room and come over to see the doctor on their own and get the treatment as well. Going by the data which is collected at the national level, with a population of 221 million, Pakistan is the 5th most populous nation in the world. And according to the prevalence data of the World Federation of Hemophilia, there should be around 23,000 patients of hemophilia. But at the national level, only around 2,500 or 11% of the total are there. So that means with this data, we know that we need to work very hard to get hold of these patients. So a lot of awareness and outreach activities required to have more patients come over to be diagnosed and then registered with our National Patients Registry. When the World Bleeding Disorder Registry started, Pakistan was one of the first countries to join the bandwagon. And this data from WWDR actually shows the age distribution and severity of hemophilia. So what does data collection help us in? It helps us to look at the clinical course of the patients, to see what happens at the end of that clinical course, what are the outcomes, and also about our hemophilia patients, their numbers and their requirements. When we follow the clinical course, we can actually make clinical decisions. Like, for example, in low dose prophylaxis, we know that even at a lower dose and lower frequency as compared to what is done in the West, our patients are still doing well. So we don't need to make any changes. We can continue on the same treatment. We can also have benchmark of our patients with other HTCs and with other countries and see if there's any real need for change. And this is very easy to go by because there's very easy access of the clinical summary of the patients, and we can actually make the clinical decisions going by the summaries we actually get. One of the most important things of data collection is to measure patient outcomes. And these outcomes are very important for us to find out how well the patient is doing. In cases of hemophilia patients, it's important to know how well the joints are doing, how much is the bleeding rate, what is the inhibitor status, what is the quality of life. In addition to this, there can be other outcomes as well on the morbidity, for example, in countries where plasma and cryoprecipitate are still used for treatment. Acquisition of hepatitis C is another thing which can be measured as a patient outcome. Moreover, we can have outcome related to morbidity, knowing what are the common causes of morbidity in a particular area. So we can have as many outcomes as we like, depending on our situation and our clinical course of our patients. So this is what is going to be rolled out or is being rolled out at present. And it is by this that patients can actually collect their own data as well and report it. At the end, I would like to say that data collection is a very important, and it acts like a magic key with which we can open many doors. And I think we should all work hard to get hold of it and use it as much as possible. Thank you very much.
Our thanks to you, Tyra, for presentation and for sharing your experience. Really interesting and powerful. We have one last question before moving to the Q&A session. One warning for you is that this time you will need to select one answer only, the one you feel is correct. While we get ready for polling, I start reading. Is a fill-in question, is an incomplete sentence. Data helps us to, and then you have to select how to complete this sentence. So data help us to track patient progress, measure outcomes, make clinical decisions, gather and maintain patient information, or all of the above. You have your option. The vast majority of the respondents selected all the above, which makes me happy and makes me feel that the presenters need an additional thank you, because either today or in previous conversation, we are converging toward a common understanding that data collection is useful to all of these goals: tracking patient progress, measure outcomes of treatment, help with clinical decision, and maintain patient information. Okay, this was our last preset question. We can now move to the Q&A section. We have an hard stop at 9:30, but we have plenty of time. I'd like to invite the presenter to come back on camera if they like and can, so that we will have a sort of a more lively conversation. And of course, Donna as well, as soon as you can on camera. Thank you. Donna will help me moderate. It's rather complex to handle the chat, the Q, at least for me, the chat, the Q&A, and maybe someone that continues to ask questions. Thank you for those who asked already. So I'd like to start with a question for Catherine and Meet, and is about elaborating a bit more, if you can and will, on the main challenge that you faced by starting a registry in Côte d'Ivoire, and how did you overcome that challenge?
Thank you, Alfonso, for the question. I will talk on behalf of Meite. So I think that one of the main problems was to convince the ethics committee about WWDR, because this is something that they are not specifically used to do in Ivory Coast and probably in other developing countries. And so we struggled a little bit at the beginning to show them that all data were processed in compliance with the privacy law protection. But the fact that Belgium was already registered since a few years really helped. And we could put in contact the ethics committee from Ivory Coast with the department of WWDR to explain all the regulations and how data are processed. So really, we served as a link between Abidjan and WWDR. And finally, after a few months, we could implement the use of WWDR in Ivory Coast.
Thank you, Catherine. This leads us to a second question, and I'm calling up Marius this time to contribute. He answered already this question in writing to the proponent, but I think it is a nice segue into the barrier that was encountered in Côte d'Ivoire. So the question is, there are local laws that prohibit sending personal data of patients abroad. How can we comply with such regulation, Marius?
Well, I can't talk for every country, of course, but most, if you look at the European regulations, they talk about pseudo-anonymization, and where you actually remove, you split the data into two. One file contains the name and the WWDR number that you keep with yourself, password protected, etc. And the other, the rest is on the WWDR. And you have to actually get two of these together to be able to identify the patient. So it's very difficult. So most countries allow de-identified collection of data, you know, for clinical study, clinical trials, etc. And I think that principle can probably apply more or less all over the place. Thanks.
Thank you. Thank you very much. And feel free to add more question if our answer and our conversation stimulates more, even on the same topic. There's no problem. Now, let me move on. There's a question that I'm not sure if we can answer properly, and I'm directing it to either Marius or Tyra or even Donna. The question is asking how patient responded when presented with the MyWBDR app. And maybe we don't have broad post-launch data yet, but we might have information that is still useful that may come from testing or from experience you may have. Are we able to answer this question in any way? What's the reaction of patient when shown MyWBDR?
Actually, I don't know. I can't answer this, but I'm just saying that a number of people don't actually have, we don't have MyWBDR with us. So, we can't, I'm not able to answer this question. Maybe somebody who has used it, Marius maybe can answer this.
Perhaps I can just start. I think if the patients aren't very economically well off, they have problems with perhaps not having smartphones, or if they have a smartphone, not having an Android or Apple phone. But the young and upcoming and keen people really took to it. And by actually phoning them and trying to talk to them, we are gradually getting more compliance. I understand it's also available in Egypt and a few other places that Tung mentioned.
Actually, I would like to ask that how can we get hold of this app for our patients?
So I can respond to that. So Tung is in the process of doing a global implementation by going country by country. So I don't know what exactly her plan is. I know you're on the list, and maybe she can follow up with you and let you know when Pakistan will have access. We're also doing like the translations and all that, so sometimes it takes a bit more time.
Yeah, because a translation, for example, in our setup would be very useful to have it in our local language, because that's what most of the people would be happy to put in their data that way.
Yeah.
Thank you.
What I can add, I don't have a personal experience using MyWBDR with my patient, but what we did, we showed the app to Canadian patient. Canadian patient, they use already an app that does some of the function that MyWBDR will do, and they use it quite consistently, and they find it very useful. And actually, whenever for some reason the system is down, we get flooded with requests: when it's back, what's wrong, when you reactivate it. So I'm hopeful that it will be useful. It's very, as Marius showed, and also Tyra showed, it's very sleek and it's very functional, very intuitive. So hopefully will become a tool that will be used on a broad scale and will help. But honestly, very good question. We don't yet have the answer. And there was a similar question that I'm parking for a second. We'll get there in case at the end. Okay, now let me move to, well, let's stay with MyWBDR. And again, maybe, I'm not sure who want to take this question. The question is MyWBDR linked to a particular HTC? To the one to Sally Yuguda, I imagine what you mean is the data that the patient collect with MyWBDR go to their hemophilia treatment center, or they go somewhere else. If this, we answer the question assuming this is the question. If it's different, please clarify it, ask again. So Maybe Donna, you want to tell where the data go?
Yeah, sure. So yes, the data is linked to the patient's HTC. So any data that a patient enters into the app will go directly into the WWDR. Their physician can see it. And they also have access to all of the data that they enter. So if they've been using it for 2 years, they'll be able to see that 2 years worth of data that they've entered into the app in the charts and the graphs that we saw on the screen. And then when they go to the clinic, they'll be able to look at their data that the patient has entered, as well as the data the clinician has entered, and view that together and have a discussion around that.
Thank you, Donna. There is a question by Titi Adeyemo that asks about maybe my WWDR is valuable tool to collect data, but will only be useful when the patient is literate. With low literacy level, we will still have to maximize the use of WWDR to collect clinical data. Meaning, I guess, if the patient can use the app, good, that's a very nice and effective way of collect data. But don't forget that we need data from patients that can't use the app. We still need their bleeding logs. We still need the information about their treatment. Thank you for pointing this out. Was, I guess, more than a comment than a question, and is a very appropriate comment. It's very important that we don't focus only on a technically capable or literate patient. That would be skewing our data. That would be against the principle of data representativeness I discussed in my presentation. So thank you for pointing that out. I'm not sure Marius may want to comment. Please, Marius.
I can just mention that there are lots of, there's a diagram of the body and so on, and color codes. So I think that somebody who's moderately literate could probably use it quite a lot.
Thank you. Okay. Another question that I'd like to try address first, and then I welcome comment from any other of the panelists, is a tough question. And it says, how as a doctor, I can know that the data provided through my WWDR are real, and the patient is not trying to disinform me to receive more treatment or pain medication. Is a very interesting question. Now, it's not just for data that come through my WWDR. How do I judge when I get a phone call that there is a bleed there and there is a need for more treatment and there is a need for pain medication? And even, when the patient is in clinic and he tells me that he has pain and he points to a knee, sometimes there's no way you see the blood, not with the a radiogram, not with the ultrasound. Now, I'm well aware that, there are settings different from mine, and I have my patient or some of my own patients that have very swollen joint. And you have no doubt there. You can get a photo of the joint, and you could ideally get it also for a bleed reported on WWDR. So I don't think the problem is WWDR. The problem is really the trust relationship between the doctor and the patient. And you cannot exclude the things like the one you are suggesting happen, but may happen independently of WWDR or other platforms. I want to make a point. One, the trust is important. These data are used to build the way we treat. So it's important to be honest in collecting and to be careful in interpreting. Also, they should not necessarily be the single way of interacting between patient and doctors. And, every patient needs a tailored treatment, including how much you trust them for their own reporting. And you know very well that with some patients, they you know them and you know that when they call a bleed is a bleed, or when they say I gave myself treatment, they did. Another, you may need, to ask the question again and so on. So I don't have any golden answer, but I don't think that using a registry and an app changes the rule of the game. The rules remain the same. You need trust and you need understanding. And you also need to understand that sometimes maybe there are patients that needs more than we do. And sometimes the doctor is right in making a treatment plan. Sometimes the patient is right in asking for more. That would be my best answer to the question. Not sure if any one of my colleagues, Tahira, please.
Yeah, I just want to say that I fully agree with you that trust is the most important link in getting the true information. And I think in the clinics, when you know your patients, you know which ones are the ones who are honest about their bleeds and things, and which ones actually improve the truth in a way. So I think you really need to counsel your patients about the value of honest record of their bleeds, and maybe that can help that can be useful in a way.
Thank you. One more question on what happened in the background. And the question is, up to what extent data can be shared with different stakeholders, including government authorities? Donna, maybe you want to say something here?
Yeah, I can respond. So if I understand that correctly, it's a HTC asking. So each HTC who is entering data has access to all of their data, which they can download. They can download it into Excel in different formats and use it and take that data, and they can provide it to whoever, regulatory agencies. In your informed consent that the patient has signed, because every patient must sign an informed consent, there is a clause in there indicating that these data, which are confidential and pseudo-anonymized, may be used for other purposes. So it might be used for research or advocacy or other purposes. So the patient has already consented to that, and HTCs have access to their data so they can use it. For the entire database, you don't have access, or HTCs don't have access without going through the steering committee governance. So I hope that answers the question.
I guess. Tahira, please. Yeah, please.
Yes, I just wanted to say, like what Donna said, that we also get a consent form signed from all our patients so that we will be sharing the data. And as far as health authorities or government is concerned, I think the data which it depends on what you want your advocacy for. For example, if you want to show them that prophylaxis is better than on demand, then that is the only data which you need to show them with graphs or whatever way you want to tell them the results of your data collections. So, or you can, for example, you can say how many patients of hemophilia you have, and what are their outcomes, how good or bad they are doing. So it really depends on the line which you want to take in your advocacy with the government or the health authority, and that is the data which you really want to show them.
Okay, someone is asking, how do they get started with WWDR? We will reach out to you after with instruction and telling you when we'll be available specifically to your country. There's another question for Dr. Lambert. Do you think the experience you reported about can be expanded to other HTC in the twinning program? Would you recommend that?
Yes, certainly I would recommend that, because in the twinning program, if you have a twin from a developed country who already participate to WWDR, it will really facilitate the implementation of using a registry in general and WWDR specifically. So this is one of the goals of the twinning, is also to share the way we collect and we use data, and to show that using outcomes from these registries will certainly improve hemophilia care in the twinning country. Yes, certainly.
Thank you, Catherine. Another question is about parents of children. Can they contribute to WBDR? How do we collect data on children?
So I can answer that. If the child is in the WWDR, the parents can enter the data on behalf of the child, and it will go into the child's medical record, at WWDR medical record at the clinic. So yes.
Thank you very much, Donna. And please, Tahira, please.
Oh, just wanted to say that in our, like Donna has already said, in the small children who can't actually express themselves, we regularly ask their parents, say, about how well they are doing or the problems and things, and enter that into WBDR. So that is the way to do it.
Thank you. One final question, maybe considering the time, is about if data are reported to pharma company. We have acknowledged the sponsor for this educational program, and we are very happy with pharma sponsor program, and we would not refuse money supporting WBDR, but that's sponsorship. Selling data is a different kind of cattle. So I don't know if you, Donna, want to comment on behalf of WFH on what the relationship is between data and pharma companies.
Yes, thank you, Alfonso. So we are funded or sponsored to develop the database by pharma companies. That's how we've been able to do all the work that we do. We don't have any intention of selling data to anybody. At some point, hopefully soon, once we amass more data, we will open the database to HTCs, physicians, organizations, and maybe pharma who have a research question that they would like to answer. So that research question would go under a governance model, which Alfonso will be part of and Dr. Lambert will be part of, and they'll assess whether the data that we have can answer that question, and if it's a feasible question for us to answer, and then we would provide them with the output of the research, but not necessarily the data.
Thank you very much, Donna. Anyone else has any comment? I don't see any more questions popping up. There would be many more, and we will ask you for feedback on this webinar, and if you found it useful, we are happy to consider repeating it beyond making the recordings available. Said that, I'm happy to thank again all the presenters for their excellent job today, and pass it back to Donna for final remarks and I guess some housekeeping notes. Thank you very much, everyone.
I'd just like to thank all of our speakers today for fabulous presentations. It was really interesting. All the recordings from this webinar will be on the e-learning platform, and I wish you all a lovely rest of day. It was nice seeing you all.